members and all the delegates, thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, TNFOG with Haryana Societies. So let us start the webinar with Saraswati Vandana. My privilege to introduce the embassy of today's webinar, Dr. Radhika Gauri ma'am. Ma'am is the specialist consultant in OBG and clinical lead at ESIC Hospital, Tirunelveli. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. Good evening, esteemed faculty and esteemed guests and all the delegates. We are here now. The TNFOG with Haryana Societies cordially invites you for the webinar on today, 26th May 2026, and I invite Professor Dr. Sampath Kumari ma'am to give the welcome address. Our Professor Dr. Sampath Kumari ma'am is a Professor HOD of Obs and Gynae in Sri Muthukumaran Medical College Hospital, and she's been the FOGSI Vice President 2022, Senate Member of Tamil Nadu Dr. MGR Medical University, and she's the National Corresponding Editor of Jogi, Founder Secretary of Tamil Nadu Federation of Obs and Gynae, and immediate past President of OGSI, Chennai, and she is a retired Deputy Director of Institute of Obs and Gynae, MMC Chennai, President Board of Studies, OG, Tamil Nadu Dr. MGR Medical University between 2015 to 19, and Chairperson of OGSI Adolescent Health Committee 2016 to 18, and she's the first ICOG Distinguished. She's won the award, the GC Member Award in 2021, and Chairperson of Women's Wing IMA Chennai South, and she has won the IMA National President's Award and IMA TNSP Award in 2021. So she's standing for the election as well. So we will all wish her the very best in the coming elections for the FOGSI President. Madam will welcome all the esteemed faculty. Welcome, ma'am.
Okay. See, somebody has asked how to do that. Sagiti, please help them. Good evening to all. Thank you, Dr. Radhika. Today we have that this is the 5th program. We have that Tamil Nadu Federation with Haryana Societies. See, today we have that Delhi Society. I welcome all of you. The Association of Delhi OBGYN Society President Neena Malhotra and Secretary Dr. Aparna, and Faridabad Societies President Dr. Kiran and Secretary Dr. Sanchal, and Colonel Society President Dr. Manisha and Secretary Dr. Parul, Rivari Society President Dr. Archana and Neeraj Secretary, and Sirsa Society President Dr. Gargi and Dr. Snita Kurana as the Secretary, Sonipat OBGYN Society President Dr. Chika and Secretary Dr. Anjali, and we have Panchkula Society, Dr. Renu and Dr. Bhavna, Yamuna Nagar Society, Dr. Suman and Dr. Manishi Mittal, Dr. Rohtak Society, Dr. Pushpa and Dr. Krishna, Palwal Society, Dr. Suman and Sadhana, and Gurgaon Society, Dr. Saroj Kumar and Neeru Thakral, and Bhivani Society, Dr. Neelam and Dr. Harsha. I welcome you all for this webinar with PAH and PPH, TNFOG and Haryana Societies. I think our chief guest, Dr. Rahini Agarwal, she is on way to flight. She may not be able to join. Now I request our guest of honors, to tell the few words and wish the webinar. Now we have Dr. Saroj, the Gurgaon Society President. Dr. Saroj, Madam, are you there?
Yes, ma'am. Good evening.
1 minute, Madam. She is the President-elect Gurgaon Medical Society and the Secretary General Haryana Observant General and life member of IMA, life member of Association of Medical Women in India, life member of ISOPA, IAGA, and had chaired more than 50 CMAs. Welcome, Dr. Saroj, Madam.
Good
Few
evening,
words about
Dr. Sampath. Good evening. First of
Okay.
all, my best wishes to you, Dr. Sampath, for your elections as President Foxy. May God.
Thank you, Doctor.
And it's my honor to be here in this esteemed society of Tamil Nadu. And I congratulate Dr. Sampath, for arranging this so wonderful webinar on PIH and PPH, which are a very, very important for our day-to-day practices. Dr. Sampath, you have already enlightened us, the whole society of Foxy, on safe motherhood as well as adolescent health. You are very nice. We are always happy to listen you. Over to you, madam.
Thank you, Dr. Saroj Kumar. I think whether Dr. Archana Yadav is there. Dr. Archana?
Yes, ma'am. Good evening, ma'am. I'm here.
Yes, 1 minute. Dr. Archana is the president of Rivari OBGYN Society and HOD of the Gynec Department at Civil Hospital, Rivari, and special interest is high-risk pregnancy and pelvic surgery. Welcome, Dr. Archana.
Thank you
Few
so
words
much,
about
ma'am.
the webinar.
And thank you for having me. And best wishes for your elections to you, ma'am.
Thank you, Dr. Archana. Okay. Sure. Dr. Vidya Prabhakar, Madam is there, our own president. She will join, I think.
Yes, ma'am.
Okay, Radhika. Now Aparna is there. We will start. Welcome all the president and secretaries. Thank you, Dr. Archana and Dr. Saroj, Madam. We will go with the first session of prediction and prevention of preeclampsia. So it's my pleasure to introduce to Dr. Kiran Chandana. Dr. Kiran, Madam, are you there?
Kiran, 1 minute, ma'am. Let me.
She is the president of Faridabad Society.
Yes, ma'am.
Anyway, no, then we can, she is the organizing chairperson for MTPCon. If she has not joined, we will introduce Dr. Aparna. Put Aparna's
Yes,
CV.
ma'am.
I take a
Yes,
pleasure in, Ramani Madam, are you there?
Yes, ma'am. Ramani madam is there.
Here, Sampath.
Yes, it will be pleasure to introduce Aparna. Ninga introduce பண்ணுங்க.
Aparna Sharma is a professor of obstetrics and gynecology, AIMS, New Delhi. She is a fetal medicine specialist with expertise in fetal intervention and treasurer of Society of Fetal Medicine 24 to 26. I've been seeing her growing from the base. She was the assistant secretary to Madam Alka Kriplani, during which time I was her. I was a chairperson in endometriosis. That time I became very close with Aparna. Still, I continue to have my relationship, and she is won the Kamini Rao Orator Junior Korean Award, Foxy Sun IAEC International Traveling Fellowship, Imaging Science Committee Award, and Rajat Rai Award for Fetal Medicine. And she has multiple publications in international peer-reviewed journals. Over to Dr. Aparna. It is my pleasure to introduce Dr. Aparna to this audience.
Thank you so much, Ramani Devi ma'am, and thank you, Sampath Kumari ma'am, for having me here today. And
Yes.
so I'll share my screen and begin.
It will be pleasant to hear her talking about preeclampsia.
Yeah. So essentially,
Preeclampsia day was 4 days back. It was preeclampsia day. So I thought when she told we will have this. Yes, sir. Yes, Aparna.
yes, thank you, ma'am. Thank you so much. And yes, 4 days back on 22nd, we had the preeclampsia day and we did a lot of activities. But I think this is something which is important. And as old as preeclampsia may be, there are a lot of newer developments in preeclampsia, and the way we manage is changing rapidly. So I thought it is a good idea to talk about preeclampsia, starting from screening for preeclampsia. So I think that is something as a practice that we all need to integrate. I'm sure a lot of people are already doing this. But when we talk about screening for preeclampsia, are we doing a history-based screening of preeclampsia? So When we do a history-based screening for preeclampsia, we look at maternal age, parity, a previous history of preeclampsia, which increases the risk of preeclampsia by almost 4 times. So that is something which is important. Interpregnancy intervals, use of ART, any family history of preeclampsia, obesity, race, ethnicity, comorbidities. So these are some of the things. So whenever a patient comes to us in the OPD in the first trimester of pregnancy, we must look at these history to determine if there's an increased risk of preeclampsia. But the question remains is that really enough? Are we doing justice by doing a history-based screening? And of course, I mean, if we do a history-based screening, we are having a detection rate of 50%, which is hardly like a toss of a coin. I mean, it can be there, it cannot be there. So that is not something that is ideal or we want to look for. So how else can we improve our screening for preeclampsia? So if you look at the data of screening for preeclampsia and you use only maternal factors, the screening result is detection rate is only 50%. If, however, to the historical factors, you add the mean arterial pressure, the detection rate will increase to 61%. Now, when I talk about mean arterial pressure, it is a simple blood pressure that we take and we put it in the algorithm to get the mean arterial pressure. So this is something that we can. So we are taking a blood pressure, but when we take it between 11 to 13 weeks and add to the historical factors, we improve the detection rate for preeclampsia. What else can we do? We add the uterine artery Doppler as a screening tool. Now we know that we all get the NTNB scan done, and uterine artery Doppler is an integrated into the reporting of the first trimester screening. And when we add the screening tool of a uterine artery Doppler, we get a detection rate of 82%. So all of these things are something that we are already doing, but yes, we must take time out to calculate the risk of preeclampsia based on these factors and give that risk to the patient and then start her on aspirin if it is required. But at this stage, what is the role of biomarkers in preeclampsia? And this is something that I want to stress upon at this particular stage. I know we are all looking at preeclampsia in some form or the other, but can we do something else? Now, if I look at a population of obstetricians who are dealing with their patients who are a little bit affording, everybody and anybody is getting a dual marker done. But can we add a PLGF to that dual marker? How much does it really add to the cost and how much additional value that can provide? So in terms of biomarkers, there are two different biomarkers, SFLT and PLGF. When we talk about SFLT, it is a anti-angiogenic marker and PLGF is a pro-angiogenic marker. In the first trimester, what we are really looking at is the PLGF and not SFLT. So only one biomarker that needs to be added in the first trimester is PLGF. And when you add that biomarker, you increase the detection rate to 90%. Now, a lot of people will say, patients are not affording, why should I do this? So whenever you say that, maybe it's time to ask ourselves the question, is the mother any less important than the baby? That is something that we need to ask. If you are getting a dual marker done, there is no reason you will not get a PLGF done. So that's a question that we need to ask ourselves and the patient need to ask. Now, the ideal protocol for screening in first trimester is combine everything, which includes maternal history, the mean arterial pressure, the uterine artery Doppler, and PLGF. Now, a lot of people will say, I am anyways getting a PAP-A done. Why should I get a PLGF done? Now, the basic fact to understand here is that PAP-A replaces uterine artery Doppler. PAP-A does not replace PLGF. So if you are getting a uterine artery done, there is no additional or added value of PAP-A over there. So yes, if you want to get your best screening protocol, you can add uterine artery Doppler plus PLGF at all points. Now, if you have a risk which is more than 1 in 100, then in that case, that means it's a high risk category. And this categorization you can easily get by going into the FFF website and putting in your details. Now, for people who would still say that, okay, this is expensive, we cannot do it, I would just say that it's very important to be preeclampsia minded at all stage. If you are not doing a biomarker, at least do a uterine artery Doppler. If you're not doing a uterine artery Doppler, at least you can do a blood pressure. Now, there's no excuse for not doing a blood pressure. So you better do a history and a blood pressure. So that is something that everybody should incorporate. Small measures like this can really go a long way in improving outcomes and early onset preeclampsia. Even today, a lot of patients come to me at say 28 weeks with severe hypertension, nulli gravida, low risk pregnancy, and all they had to do was to start aspirin in the first trimester, which was missed. The preeclampsia, which was missed, because it affects the nulliparous women, low risk women, even the low risk women. So there is no excuse for not doing a preeclampsia screening. Now we are doing so much fanfare about preeclampsia screening. So what is to be done after that? So what we really need to give is just aspirin. There are no other non-pharmacological interventions like bed rest or restriction of physical activity, or even heparin. A lot of people would start patients on heparin unnecessarily with a raised uterine artery Doppler. There is no evidence to say that. All you need to do is start them on aspirin in the first trimester after you're at high risk for preeclampsia. There is no role of sodium restriction, any dietary protein energy intake. But yes, calcium supplementation remains a very, very important factor because most of our women are calcium deficient. So 1.5 to 2 gram of calcium. Also, vitamin D, there is some kind of a role. So if you're deficient in vitamin D, there is merit in giving 250 international units, but we don't have to overload them with thousands of international units. So these are the only interventions that really work for prevention of preeclampsia. And these must be undertaken from the first trimester of pregnancy itself. Now, as regards the aspirin, we know that a lot of societies do give a lot of guidelines, but in terms of evidence, which is there on an RCT, so the ASPRI trials tells us about aspirin, which is 150 milligram per day, started before 16 weeks and to be given at night. So when we talk about aspirin, we only have to say three things. One is before 16 weeks, second is 150 milligram, and third is at night. So if we want aspirin to be effective, we need to follow these things. Also, compliance is very, very important. So a lot of people do come up and say that, why do you want to go for all of these expensive testing? Why not just start aspirin for everybody, universal aspirin? Why doesn't it work? Now, the point is, whatever you give universally, nobody is going to take. The compliance is going to come down. It is going to be like iron and folic acid. Nobody will follow the protocols and nobody will stick to that. And evidence has shown that if you give less than 90% compliance, the efficacy falls down. So yes, that is the merit in actually screening and starting aspirin rather than giving it to everybody. So this was the landmark trial, ASPRI trial, which told us that yes, aspirin should be started with these three criteria. Now, a lot of people come and say, okay, my blood pressure became high at 24 weeks, so now I have started aspirin. But now that wave of placentation is over, this is not going to help you. Unnecessary interventions. Today, I had a patient who was on aspirin, heparin, injection, Hermin at 29 weeks of gestation because she was detected to have high blood pressure at that point in time and FGR. So kindly, we need to refrain from doing all of these non-evidence-based practices because they're not going to help. So if you really want to help your patient screen in the first trimester, start aspirin before 16 weeks. That's the best outcome that can there be. Now, what I'm going to talk about is something that may not be, currently being done everywhere, but we at AIMS, we have completely transformed our practice using biomarkers in preeclampsia. So that is something that has come up. It gives you a lot of information on how your disease process is going to be. Just a minute. Sorry. So yes, I'm going to talk about how SFLT PLGF ratio is going to talk about diagnosis and prediction. Hello? Sorry. So basically in diagnosis, prediction and role in established PE. So basically it all started with the prognosis trial, and it told us that if you are at a gestation age of less than 34 weeks and SFLT PLGF ratio is less than 38. Now I'll just quickly tell the importance of the ratio of less than 38. Now SFLT is a anti-angiogenic marker and PLGF is a pro-angiogenic marker. So higher the ratio, the more problematic it is. So if you have a ratio of less than 38, then it will tell you that, okay, this lady does not have preeclampsia right now, and will not develop preeclampsia in the next 7 days with a very high probability, very high negative predictive value. If, however, the ratio is more than 85, she has preeclampsia, whether there is proteinuria, whether there is no proteinuria, whether there is organ involvement, there is no organ involvement. So a value of more than 85 will tell us that, okay, this patient is preeclampsia. So I'll just give you an example of how this really works. So this lady, she was a doctor, 35-year-old with mild pedal edema, 35 weeks, 29-year-old, occasional high blood pressure of 140/90. Now, this patient, she came to me, we did some urine protein as is indicated, and this was negative. Now, in my normal situation, I will say, okay, this is just maybe some occasional high blood pressure readings. I don't need to get involved. So, but that was the time that I started doing SFLT PLGF ratios, and she turned out to be 162, which is definitely much higher than 85. So we labeled her as preeclampsia and we induced her at 37 weeks. During her labor delivery, her blood pressure went to 170 and 100 and required IV injection. So this is like a preempting the disease process which is happening in the body. It is going to tell us that, okay, is this going to worsen? Is this not going to worsen? So this is an extremely helpful biomarker. In another situation, this was again a doctor who was 31-year-old primi gravida, no other high risk factor, but she was positive for preeclampsia screening in the first trimester, was on ecosprin 150. Now, everything was okay till the second trimester when she showed an early onset fetal growth restriction. Now, when you have an early onset fetal growth restriction, you are worried that is there something wrong with my baby or is there a placental issue? So it turned out that, okay, everything was normal anatomically and she refused to get an amniocentesis done. When she came to me, I got the SFLT PLGF ratio done and it turned out to be 192. So that's a definite high value, more than 85. And it tells us that, okay, there is some uteroplacental insufficiency. So there is some angiogenic imbalance. And we told her that, okay, your baby is small because of uteroplacental insufficiency. There is no genetic cause as such. So we kept monitoring that patient bi-weekly. At 29 weeks, she developed an absent and diastolic flow and delivered a 1,000-gram baby who later on went on to do very well. So this kind of reassures you, tells you also that, okay, what is the cause for your uteroplacental insufficiency? So one single test can tell us, okay, is there a placental issue here? Now, another important aspect is prediction. So now you have a lady who does not have any problem right now. And this was the crux of the prognosis trial. And if you have a ratio which is less than 38, it will rule out preeclampsia. But if it is more than 38, then the patient might develop preeclampsia in the next 4 weeks. So this was later on confirmed by many more trials like the INSPIRE trial or Prognosis Asia trial. So the numbers that we need to know is 38 and 85. So if it is less than 38, then she does not have preeclampsia, not likely to develop preeclampsia. But if it is more than 85, she already has preeclampsia and will develop. So a case in point here is there is a 35-year-old lady, again a doctor, 130/85, again pedal edema. Now, similar to the other case, I was not sure how the course is going to be. And when we did her ratio, it was 4.09. So I said, okay, relax, nothing's going to happen. Continue the pregnancy. And we allowed her to go into spontaneous labor and she delivered and never had a high blood pressure. So this is something which is going to tell us what is the milieu inside, how the things are going on, and how should we go about it. Now, is there a role in established preeclampsia? A patient whom you have diagnosed as preeclampsia, it tells us the interval between diagnosis and delivery, how long the pregnancy will continue. So, for example, if the ratio is more than 85, the patients deliver within 6 days. If it is less than 85, it can go up to 2 weeks. So, even in patients of proven preeclampsia, we get these tests done to understand, okay, how serious the thing is going to be. So just a case in point, this lady was 33 weeks and 5 days. She had a complaint of headache, 150/102 blood pressure, but we admitted her, controlled her on antihypertensives, started on labetalol and discharged after 3 days. Now, this is something that you would routinely do. But what happened? Before discharge, we did send the sample, but we did not wait for the report to come. Now, what happened after 3 days is that she had an abruption and needed an LSCS for fetal distress. and her ratio was 89.22. Now, if at that point of discharge, I had known that she has such a high ratio, I would anticipate some problems, anticipate that she's going to deliver within 3 days, maybe discharge her, maybe observe her for some more time. So it is going to give you an idea on the disease course. Sometimes we've had patients who have ratios at the level of 500 and 600 and they'll deliver within 48 hours. So that is something again which is quite useful. So delivery timing from presentation to delivery is something also which can be predicted by doing this. This is our paper on the use of SFLT PLGF ratio in around 40 to 50 patients now. And more than 38, it was seen that more complications of preeclampsia, shorter time to delivery, and the ROC for identifying patients at risk is around 0.8. So anybody who had a ratio more than 38 had adverse fetal-maternal outcomes and shorter enrollment and delivery period. Another important aspect that we are currently doing as a novel concept is SFLT PLGF ratio in early onset fetal growth restriction. In our case series, we found that all of the women who had higher risks generally did not have any genetic disorder. So any woman who comes to us with an early onset fetal growth restriction, this is a new test that we do to rule out fetal growth restriction and uteroplacental insufficiency. So to actually look at the SFLT PLGF ratio as a guiding test for management of preeclampsia in your day-to-day practice, for prediction of preeclampsia and for diagnosis of preeclampsia. Another interesting concept is of the point of care devices in preeclampsia. And we did a study on the Congo Red test, which is like a urinary pregnancy kit test. And if this test is negative, you are very highly unlikely to develop preeclampsia. So this is again a very point of care test, which can be used in the peripheral areas, just like a urine pregnancy test. And if you are in doubt, she has a borderline blood pressure, her urine albumin is negative. Now you're in doubt whether she's going to worsen, she's not going to worsen. You can do this test and also determine that, okay, this lady is not going to develop preeclampsia in the next 7 days. So with this, I know it's been like a little heavy on the biomarkers, but it's important to really explore the new concepts that are coming in, how the management can differ by knowing these biomarkers. So the current role of PLGF is in screening, and the ratio of SFLT and PLGF is there in terms of diagnosis. It is there for prediction and also to understand the course of the disease. So in the first trimester, it is our duty to use mean arterial pressure, uterine artery Doppler, and PLGF for a detection rate of 90% of preeclampsia. And in the second trimester, we have the total, we have the tests of SFLT and PLGF for screening, for prediction, and for monitoring of established disease. Thank you very much.
Thank you, Aparna.
That's an excellent presentation, I should say. And somebody wanted to know about the cost and how long it will take for the test results to come.
Yeah. So, ma'am, actually, it really depends on how much we start using it, as we all know. I think it's very important. So, currently it is priced at 3,000 rupees. And in most of the metro cities, the well-known labs, they are giving you the reports in 48 hours. At AIMS, we have an in-house lab, so we get the reports free of cost in a few hours. That's what we have developed here. But otherwise, I think it's the usage which is going to bring down the cost. Another important thing I want to say is that you have to ask your labs that whoever is doing the dual marker can give an additional of PLGF for a hardly any cost of 500 to 600 rupees. So we cannot have the excuse that it is expensive. If you are getting a dual marker done, kindly ask your lab to provide PLGF for an additional cost of hardly 500 to 600. And if they are not giving, please let me know.
We are doing it. PLGF, we are doing it. And for needed cases, I am doing the ratio, but only thing is it takes around 72 hours for the result to come. And that the Congo Red test also seems to be very impressive.
Yes, so we did it so it was a multi-centric trial that we did in Delhi with all the Delhi hospitals, and we did it in 600 patients. So that's also a very interesting test to at least reassure yourself that, okay, next 7 days she's going to be fine and we can do it.
What's the cost of that?
So that kit cost is placed at 600. So that's also a good test to have. Yeah.
Okay. Thank you.
Fantastic, Aparna. Super. Yes,
Ma'am,
we are not doing hereafter. I think we have to start doing 3,000 rupees means it's okay now.
ma'am, chairperson Dr. Kiran ma'am has joined.
Yeah.
Hi, Dr. Kiran. Dr. Kiran Chandana, have you joined?
She is there, very well there. Unmute, Dr. Kim.
Yes, ma'am. Good evening, ma'am. I have just joined.
Yes.
I was not able to join with the link. Now, just I have joined. I have missed this talk.
Yes, fantastic. You will have it in the YouTube. Anyway, we will keep all the programs in the YouTube. She gave a fantastic talk. I introduced on behalf of you, Kiran. Aparna Ramani Madam has introduced. Good talk you can have in the YouTube. Thank you for
ma'am.
joining, Dr. Kiran.
Thank you, ma'am.
You be in the panel with Ramani Madam for expert.
Yes,
Dr.
ma'am.
Sugasini will be conducting. Thank you, Aparna.
Thank you, ma'am. Thank
Yes.
you.
Radhika, can you introduce Dr. Sugasini? Next, we will go with the second session of the panel. The moderator is Dr. Sugasini and the experts are Dr. Kiran and Dr. Ramani Devi Madam. Who are panelists, I think, because the doctors have not renamed it. I want to know whether Dr. Rashmi, Dr. Priyanka, Dr. Neeru Thakral, all of you are there. Dr. Lakshmi Menon, Dr. Ranjana, Dr. Neeraj Yadav. Dr. Rashmi, are you there?
Yes, ma'am. Good evening, ma'am. I'm there.
Yes, Dr. Rashmi is there. Dr. Priyanka?
Good evening, ma'am. This is Dr. Priyanka.
Yes, Dr. Priyanka. Then Dr. Neeru Thakral? She is not there. So Rashmi is there, Priyanka is there. Dr. Manisha Singhal? Okay. Dr. Neeraj Yadav?
Hello.
Okay. Dr. Lakshmi Menon?
Yes, ma'am, I'm here.
Yes, ma'am.
Yes. Dr. Ranjana?
Yes, ma'am.
Yes. Dr. Sugasini? I'll introduce Dr. Sugasini. Dr. Sugasini is the registrar in Sri Muthukumaran Medical College in Chennai. And she has done her UG in Jangalpat and PG in Rainy Hospital. And she is the life member of all societies. And she has given talks in many national conferences. Yes, back to Sugasini. Sugasini, you can start.
Thank you, ma'am.
Start
Good evening
introduce
to
Ramani
everyone.
Madam. Hey, Ramani
Yes.
Madam, introduce.
Yes, ma'am. Good evening, Ramani, ma'am. She is the president of TNFOG 2024 and the national vice president FOXI 2020, managing director of Ramakrishna Medical Center LLP and Janani Fertility Center. She is a patron and president for the Tamil Nadu Federation of Obstetricians and Gynecologists, executive committee member of Endometriosis Society of India. She has won 10 gold medals in UG and PG and 5 FOXI awards. UNICEF certified master trainer for violence against women. Winner of Dira Award for contribution to violence against women. MS Signature Award for academic excellence and innovation in fieldwork. Dr. Steya Paul Awardee 2022 for academic excellence. Asia GCC Award for academic excellence 2021. She authored more than 30 topics for books and more than 23 scientific papers in her name. She is a principal investigator of Boyce trial published in Lancet. She is the editor of Endometriosis Update published by Endometriosis Society of India, and she has citation for 2,536. Good evening, ma'am. It's a pleasure to introduce you, ma'am. Welcome to the panel expert opinion, ma'am.
Thank you. Thank you.
So, I'd like to introduce the panelists. Yes, ma'am. So the first panelist is Dr. Rashmi Ahula. She's a private practitioner for more than 16 years in Obs and Gynae. She's a life member of FOXI, Faridabad and Menopause Society. She's interested in high-risk obstetrics, ultrasonography, and gynae endoscopy. Next panelist.
Dr. Priyanka Sharma.
Can I have the next? Yes. Dr. Priyanka Sharma. She's a professor in the Department of OBG, ESI Medical College and Hospital, Faridabad. She's completed Advanced Medical Education ACME 2024 in MAMC, New Delhi. She's an MD gold medalist, 15 years of post-PG teaching experience. She's an MD guide and a PhD co-guide. She completed advanced course in medical education from MAMC.
Manishi Mittal is there. She is not there, I think. Are you there, madam? No, she is not there. Next slide, Sagiti. Neeraj Yadav. No, then Lakshmi Menon only. Yes, Lakshmi Menon. Lakshmi Menon is the assistant professor at Sri Muthukumaran Medical College. Welcome, and she has done her UG in Calicut and PG in Manipal. Next slide.
Dr. Neeru, Dr. Ma'am.
No, she is also not there.
Dr. Manishi.
Manisha Singh. No. Dr. Ranjana.
Dr. Ranjana is there.
She's an assistant professor in so I welcome all the panelists.
Sugasni, you have Rashmi, Priyanka, Lakshmi Menon, and Ranjana. Okay.
Okay.
Start.
So I'll start my screen. My screen visible now?
Go to slideshow and start.
Okay. So we all know that PPH remains the leading cause of mortality, accounting for about more than 20% of deaths globally, and it remains a nightmare for all the gynecologists even now. And coming to the definition, the earlier definition according to ACOG and RCOG was loss of more than 400 ml from the genital tract or more than ml during cesarean section of RCOG. These were all previous. We have the panels about the new definitions. Dr. Rashmi, ma'am.
Yes, yeah, actually, according to the new definition, any blood loss that brings about a change in the hematocrit value or the hemodynamic stability of the patient is considered as PPH. Initially, we were using as amount of blood loss as either 500 after a normal delivery or more than 1000 after cesarean section. But now any changes that brings about hemodynamic instability is considered as the PPH.
According to new definition, even the both vaginal and cesarean sections are considered significant, or a loss of more than 300 ml with any of the following, like systemic BP less than 50 and the diastole less than 60, pulse rate more than 1, whichever occurs earlier. So going to the first case scenario, she's a 25-year-old woman, G2P1L1, 39 plus 4, delivered female baby, weighing 3.2 kg. She has no antenatal risk factors, and the third stage was as usual managed by the active management of third stage labor. 15 minutes after delivery, she develops a heavy vaginal bleeding. Initially, her vitals were like heart rate was 120 per minute, BP is 92 by 56, and respiratory rate is 24. The patient is pale, alert, but anxious, and the estimated cumulative blood loss approximately it was 1100 ml, and it is still ongoing. And when you do the palpation, the uterus was still boggy. So what is our diagnosis and what will be the next step? Like we have done the active management of third stage, will be our next step like uterotonic and medical management. Rashmi?
In this case, sorry,
ma'am, it's a case of
sorry.
primary PPH, ma'am, probably atonic uterus. So we have to start resuscitative measures. We have to immediately put IV line, start crystalloid resuscitation. In the meanwhile, get blood. The patient also, even though the active management of third stage of labor has been done, the emotive full protocol should also be followed. Oxytocin should be given, massage of the uterus should be done, and we should see how the response is to the initial management measures.
So what are the other can use apart from oxytocin?
Other than first, it should be oxytocin, 10 units IV or IM, and then afterwards oxytocin infusion, 20 units in 500 ml normal saline should be given. Following which, if the patient is still not responding to that, we can give carboprost, then Methergin, and repeat the doses as required.
How frequently can you give maximum doses?
We can give
Carboprost.
maximum of 8 doses. For carboprost, up to 8 doses can be given, ma'am, 15 to 20 minutes
So it
apart.
can be repeated. Yeah.
Yes, ma'am, can be repeated. Then misoprostol per oral can also be 600 to 800 micrograms per oral dosage can also be given if the response is not there to any of these drugs. We should also give injection tranexamic acid, ma'am. Up to 2 times also it can be repeated.
What of carbitocin?
Carbitocin is more
Rashmi
for
ma'am, can you-
prophylaxis, ma'am. It is not very useful in the management of PPH. However, it can be given prior to the procedure itself, prior to cesarean or prior to delivery.
So and single dose, either IV or IM can be given 100 ml. And it's very administered also. Only one therapeutic can you go for other proteomics. So champion trial we to prove that it is non-inferior to oxytocin of a single dose administration. So if at all we are giving acid, what should administer and what is the dose? Dr. Rashmi,
Champion trial.
or Dr. P.
So heat stable I'm getting a lot of disturbance in the reception from your end. I don't know if you can hear me properly. So, I assume you're asking me about tranexamic acid? Or is it carbitocin?
Tranexamic.
Okay, so tranexamic acid is an antifibrino. Excuse me? So I'll start with tranexamic acid. Tranexamic acid is an antifibrinolytic agent. It is usually given once the diagnosis of PPH is made, and it should be given irrespective of whether it is an atonic or a traumatic PPH, because it affects the coagulation pathway in both manners. So it is best to give it within 3 hours of delivery of childbirth, and for the more delay that administration of oxytocin incurs, the higher is the chance of having an adverse outcome. So every, say, 15 minutes delay can increase the rate of mortality by about 10%. So there's no use of giving it after 3 hours. It is important to give this injection very slowly. 1 gram should be diluted and given over a period of 10 minutes because it can cause transient hypotension. And we can repeat another dose after 30 minutes. If there is no decrease in the amount of bleeding that has taken place. So it can reduce the mortality rates. So trials have shown that it can reduce the mortality rates to as high as 30%. So it's a very effective intervention.
Yes. So earlier they give about the advantage reduction in the bleeding and also the maternal mortality. So coming to the next question, what are the common causes of you all know that's the 4 T's. Can one of us take up the question and just finish it fast of the 4 T's?
So the 4 T's are basically tone, which is most common. That is about 70% of the cases because of atonic PPH. Then trauma, which could be injuries to anywhere in the genital tract, starting from the rupture of the uterus to cervical tears, to vaginal tears, to perineal tears, broad ligament hematomas. Then we could have tissue, which could be retained placenta, or it could be membranes, or some POCs that are left behind. And again, it could be thrombin or coagulopathies that patient may have beforehand or may develop because of PPH, secondary to PPH as well.
Yes. So these are the causes which have been listed, which is a pre-existing condition like thrombocytopenic purpura, hypertensive diseases, uterine myoma, anticoagulant therapy. So BMI more than 35, age more than 40, and uterine overtension, multiple gestation, acromelia, prolonged labor, disorders of placenta, uterine genital tract. So how are we going to identify PPH or diagnose PPH? What are the early
Ma'am, first of all, we should be
Dr. Anna,
cautious. Sorry. Ma'am, shall I answer this
you
question?
can.
Yeah, no, ma'am, the signals are getting
So your
interrupted.
voice is breaking a lot, actually.
Yes, ma'am. Yes, we are not getting it completely. Ma'am, first of all, we have to be very vigilant during the
Signal
antenatal
drop.
period.
Yes.
Yeah, first of all, a patient having low hemoglobin, patient having high risk factors like multiple pregnancies, polyhydramnios, or having any fibroid uterus, or a prior history of PPH in previous pregnancies. Single time or multiple times if there is a history of PPH, or there is any coagulopathy in her history, any liver disorder, or any chronic medical illness, then we should be cautious that the patient may have PPH during her delivery. And then during labor, we have to be cautious. We have to we have to take active management of the third stage of labor. And if still the patient has bleeding, which is causing disturbance in the vitals, like the pulse rate is exceeding, the BP is falling, or the respiratory rate is exceeding, or we have the shock index is going more than 0.5, then we can diagnose early that the patient is having PPH.
Yes, Dr. Rashmi has explained very well. Sugasni?
Yes, ma'am.
You can get the opinion from Ramani madam.
Sorry, ma'am. Please repeat, ma'am. What did you last say, ma'am?
You can get the opinion from Ramani madam. Ramani madam is there, no?
Yes,
Rashmi, you did very well, I told her.
Okay,
I
thanks,
think
ma'am.
the panelists are giving a exact answer what has to be done. And first thing is, anticipate who is going to have PPH and what are all the intrapartum problems the patient may face. And then in anticipation, you have to thoroughly use that emotive bundle. Don't stop only with you can go in for a prophylactic carbitocin. Even if carbitocin is used, in spite of that patient has a bleeding, there is no harm in starting the patient on oxytocin or prostaglandin. And rightly, you have pointed out that tranexamic acid is of much value both in atonic PPH as well as in traumatic PPH. So first thing is quickly assess the general condition. Then see, sometimes we can have the combination of atonic PPH with cervical trauma also, especially when you have applied forceps. So always do a quick examination to see that the cervix is intact. So that rules out to some extent your traumatic, which should have been corrected with a simple suturing. So I think this has to be thought in mind. And again, get ready for blood, and then all the other things. Like I think most of the things you have covered. And when you are using that crystalloids should be preferably used, and blood products should be available at any time. So it is always safer to be prepared for postpartum hemorrhage. And I think the point, what I liked was always PPH means a standard blood loss of 500 or 1000. But now, yes, that thing has changed. Whenever the patient has got hemodynamic instability, because an anemic patient with a simple even 200 ml of blood loss, she is going to collapse. So that is more important than the exact amount of bleeding the patient is going to have. All of you have given an excellent answer.
Am I audible, ma'am?
Yes.
Am I audible? Yes. Okay.
Yes.
The next question to my panelists are how to estimate the blood loss. We all know estimation of blood loss plays a vital role for the management of PPH. So how are we going to estimate this?
We can estimate blood loss. We have a subjective estimation and an objective estimation. So the subjective estimation is visual estimation of blood loss. We have a clear pictorial representation of how a partially soaked pad will be 30 ml, fully soaked pad will be 100 ml. Incontinence pad, if it's soaked, it will be So that is already established. So we can use that. However, that differs from one practitioner to another. So it is probably better to go for an objective estimation. And objective estimation, you can either use a gravimetric method where you're taking the soaked materials and then subtracting it from the dry weight and then using a conversion of 1 gram is equal to 1 ml of blood. But again, that also varies. That might not be so accurate. So now, according to the emotive bundle, we have those calibrated drapes that we're using. So that is probably the best method for estimation.
Yeah, nowadays we are using all drapes and then collecting that. So that will give us the best estimate.
Now this calibrated method
So this is
drapes
how we
are
get
available
one.
from Foxy. In the Foxy, the Atuna project,
Yes.
they are using this calibrated drapes. It is available in many of the places. Yes, Sugashni.
Yes.
So,
the
ma'am,
next question to my panelists is what is shock index?
If I could add on a little bit, especially in cesarean
Yes.
sections, it becomes difficult to estimate blood loss. So it is very important to mark the amniotic fluid before we start measuring blood loss, because someone should either change the catheter or should mark. The other thing is we could put the patient in a slightly reverse Trendelenburg position so that all the blood, and we can apply drape at the foot end of the patient. So that encourages the blood to collect in the blood bag. If the patient is in a low lithotomy, in a reverse Trendelenburg position, especially when we are doing cases of placenta accreta, etc., there are some suction catheters also available which can suck the blood around the drapes and bring them into the bag. So these are the things, because in cesarean sections it becomes sometimes difficult to estimate blood loss.
Yeah.
Yes, Priyanka, this amniotic fluid collection will we will have a misguide. Yes.
So the next question is what is shock index? We have talked about the shock index. What is it exactly?
Shock index is actually the product given by heart rate divided by systolic blood pressure. The normal value is actually ranges between 0.5 to 0.7. But if a value is more than 0.9, we should be cautious and may need blood transfusion in the immediate future. And
so it is more than 1, then we should be very cautious in
yes, that is a
managing the
critical
patient.
value. More
So what
than
is
1
rule
is
of 30?
Rule of 30 means,
Yeah.
that is,
So what is rule of 30?
that is a systolic blood pressure falls 30 millimeters of mercury, or her heart rate increases by 30 beats per minute, or there is a respiratory rate more than 30 breaths per minute, or when the urine output is less than 30 ml, we should assume that she must have lost at least 30% blood volume. This will come around grade 3 shock.
So we should never forget about this rule of 30. 30 is very, very important in management of PPH. So we have done all the uterotonics we have given. We have
Yeah.
sorry, there's so it's getting. Am I audible, ma'am?
Yes.
Your voice is cracking. It's not very much clear.
So I think the signal disturbance is there. So if the bleeding is continuing after uterotonics and Tranexa, then what is our next step?
So after
the
we've
patient
given
to create
Yes.
If conservative measures are not working, then we should go forward with the initial surgical measures. And the first step should always be bimanual compression. Compression and tamponade. RCOG says this tamponade should be done as early as possible. So with that itself, a majority of the atonic PPH will generally respond. Nowadays, if you need to transfer the patient from to a higher center, then you can use anti-shock garments as well. So that gives you some time for that transfer to happen. Other than that, aortic compression is also a good method to conservatively manage. However, we should not wait too long. If the atonicity is not responding or if the PPH is continuing, it is better to go for a laparotomy and go for surgical measures.
Suhasini, I would like to say, see, you definitely go ahead with the bimanual uterine contraction as the initial step. Then uterine tamponade. Uterine tamponade, it's keeping a SR cannula is much easier than a uterine tamponade. What do you think? It's very practical, very simple. I think every labor ward should have a SR cannula, because the moment you see atonic PPH not responding to the medical management, instead of going and searching for a not searching, instead of going and doing a cumbersome uterine artery tamponade, you just put in the SR cannula and then connect it to the suction. So that will, in no time, it will get relieved. So that is, I feel my experience with the SR cannula is definitely much more than that of the uterine, uterine tamponade. I would also like to share one incident, see, where a case of placenta previa, very confidently before closing, I just put in a condom tamponade. So for that time, it was okay. But after 2 hours, what happened was the space between the condom and the uterine cavity, it got filled up and the blood seeped into the myometry. So always when you are putting the condom tamponade, we have to be very careful that the size of the fundus is not increasing. Okay, so better than this balloon tamponade, I personally feel SR cannula is very, handy. You can get the results very quickly. And as you have mentioned that non-pneumatic anti-shock garment should be there in every labor ward, which handles quite a good number of things. And that is also, you can immediately, the staff can be taught about it. You can immediately put that. And then if you need to transfer, that will be an adequate, wonderful method of transferring to a higher center. Suhasini, where are you?
Yes, ma'am. I'm there, ma'am. I just can't.
So if we are going to close it, I would like to ask one question from the panelists. Suppose if you have done ligation of the internal iliac artery for atonic PPH in the first pregnancy, we should anticipate PPH in the subsequent pregnancy also. Okay, then how you are going to manage? Because already you have done internal iliac ligation, and she will have lot of this collaterals. So what can you do? Suppose if she has a anticipating PPH in the subsequent pregnancy.
We should counsel them on the risk of obstetric hysterectomy, ma'am. Other than that,
think over, conservative.
Ma'am,
transcervical clamps.
Ma'am, we can offer her uterine artery embolization prior to the surgery.
Yes, uterine artery embolization. Okay, agreed. Then
aortic clamps
very
can
simple
be
thing. Uterine artery
reduce the blood loss.
is not available everywhere.
So we can go
Just
in
transcervical clamps and
hemostatic sutures can
aortic
be
clamps
applied.
can be used.
You have done a C-section for her. Patient is on the table. She is bleeding. Previous previous internal artery ligation done. What can you do?
So we can go ahead with putting the belate
compression sutures.
Compression sutures.
Belate suture can be put in.
Because the mode of action is that is going to be different. Our best thing is you put in a SR Panikkar cannula. This was one situation I had, and wonderfully there was there was no bleeding at all. I just inserted the Panikkar cannula, waited for some time. There was no bleeding, then closed and came back. So either a compression, because we cannot go for a repeat internal artery ligation. That we have to understand. Either compression or this SR Panikkar cannula. Okay. So Hasini, what is your next case?
Suhasini, Aparna is there. Aparna, are you using Panikkar's cannula in AIMS? No, Aparna has left, I think.
Yes,
நம்ம
yes.
Ma'am,
சவுத்துல தான் மேடம் யூஸ் பண்றோம்.
In ESI Faridabad, we are using it very often, and we are getting very
Okay.
good results with the
Yes.
Panikkar cannula.
Panikkar cannula. Yes, it is a
Hello,
wonderful.
hello, Dr. Sampath. Hello, Dr. Sampath.
Yes,
Yes,
madam.
I am
Saroj.
using Panikkar cannula. I have used many a times. Every time it was affecting, no failure.
Yes. Yes.
Yes, sir. Panikkar cannula is good.
Yes.
You can use it.
In our
When we were
society,
in
we
the
have distributed these cannulas also. Approximately 50 cannulas we have distributed to our society members, and they are all using it. Suction
in Tamil
cannulas.
Nadu government, they have distributed to all the medical college the Panikkar cannula.
And Trichy district, we all got non-pneumatic anti-shock garment. Many of
That is
people-
also there.
That is also very useful.
So always the 4 T's. That's all. Sugashni, do you have any other?
Next case scenario.
Yes, you go with the next scenario.
So here's the second case. She's a 26-year-old Mrs. X, P1L1, referred from a private hospital with complaints of bleeding per vaginum since delivery. She was medically managed with uterotonics, fluids, and 1 unit of PRPC transfusion. Still, she is bleeding. So what will be our next step?
I want to know what is the time since delivery?
Duration.
Maybe 1 hour.
Okay. So first of all, we would call for help. We need at least 3 people to manage PPH. We would resuscitate the patient, put 2 wide bore IV cannulas. If she's come with medically managed, she is likely to have IV cannulas in place. Her bladder should be catheterized. The uterus should be massaged if it is atonic. Then we should give IV fluids. At least 500 ml of normal saline can be given over 30 minutes. To keep the BP above 70 mmHg, systolic BP, mean arterial pressure over 60 mmHg. We can also.
So what do you think could be the cause for her bleeding, ma'am? We have given uterotonics, fluids, everything. So
we have to examine her for any if the uterus is well contracted, we have to go ahead and look for other causes. So we need to empty her bladder, we need to inspect her for any tears, and we need to get a coagulation profile done as well to check for why she is bleeding.
So two things we have to keep in mind. One is our trauma and then the tissue. So you do a bedside ultrasound also to look for any retained products of bits of placenta or membranes. And then traumatic also we have to rule out. And if any trauma, then we have to suture it properly. A word about massive transfusion protocol. Can any of the panelists take up the question?
Giving about 10 units of blood in 24 hours. This is called massive transfusion, or giving a total replacement of blood within 24 hours.
So what will be the ratio in which we are giving this FFP, and what are the things we will give and at what ratio?
1:1. FFP is to platelet is to PRBC 1:1:1 ratio. Yeah.
Yes. So and then if she is RH negative, then we'll be giving an anti-D. So massive transfusion protocol, you have to initiate when patient is requiring. So what will be our goal? We have to keep the hemoglobin at 10 grams, platelet at 32. Platelet is more than 50, and PT and PTT is more than less than 1.5 times the control, and fibrinogen is more than 1.5. So the next case, she's a 27-year-old G2P1L1, previous LSS, LCB is 1 year. 17 weeks of gestation, she was complaining of spotting per vaginum. An ultrasound showed low-lying placenta. She was treated conservatively. After 4 days, she complained of expulsion of the fetus and the placenta in bits. It didn't come in total, it is placenta in bits. So what's the diagnosis here? And how are we going to manage?
Most probably it is the retained placenta, or an urgent ultrasound will have to be done to rule out retained placental bits, and secondly any scar dehiscence. This has to be ruled out. An urgent ultrasound will make us.
She's a case of previous LSCS, and we have this placenta inside. Anything
It
else
has
can
been removed in
think
bits.
Yeah, we have to think about placenta accreta. We had to proceed. So this scenario, here is a 27-year-old presenting on day 12 postpartum with excessive vaginal bleeding and forced smelling discharge. She had a spontaneous vaginal delivery at home. Her findings were heart rate was 98, BP 160, and uterus is 14 week size, subinguinal mildly tender, speculum examination, foul smelling discharge. The hemoglobin was 8.9 and alpha stored echogenic material, retained echogenic material. So what's our diagnosis?
Sepsis.
Retained
Postpartum
placenta.
hemorrhage, most probably due to sepsis.
Most likely puerperal sepsis because
she's
some
landed
infection.
in secondary PPH.
Likely because
Yes,
of infection.
So we are giving a cover of antibiotics, IV antibiotics, and then ultrasound guided TNE if required after 48 hours of IV antibiotics. And correction of anemia simultaneously and stabilization of the patient. So keep finding here a primary cavity liver 0.5 kg with an episode in the middle of the night. A junior doctor has sutured. 2 hours later, there was a call from the ward complaining of severe pain in the vulval region. So what the diagnosis here?
We cannot see the question. It's likely to be an episiotomy hepatoma. Episiotomy hematoma, but the question is not on display on the screen.
Basnik, what is the question?
Next.
Can you repeat the question? Priyanka is not able to. What is the question? Question is not seen in the screen.
Tiny. Yes, tiny delivered 3.5 kg. Episiotomy done in the middle of a night by a junior doctor. And 2 hours later, there was a call from the labor ward saying patient complaining of severe pain in the vulval region. This is our probable diagnosis.
Voice is not audible. Priyanka, can you see the
Vulval
question?
Yes, ma'am, I
hematoma.
can see the question. This is likely a cause of traumatic PPH because of an episiotomy which has not been properly sutured. So, do you want me to tell the management of what is the question exactly?
Normally, if the apex
management.
is not sutured, there will be a big hematoma. Most of the time, they will be seeing in the abdomen itself. The apex may not have sutured. So that time, the hematoma will produce all changes. I think Sugasni is going for the same. Yes, Sugasni.
Yes, ma'am. Yes, ma'am. Can the panelists tell us what the hematoma? How are we going to manage if it is a small hematoma and not increasing in size, and if it is a big hematoma and increasing in size?
So if it is a small hematoma which is not causing any hemodynamic instability, if the vitals of the patient is stable, if her HB is stable, and it is not growing in size, it can be left to resolve on its own. If required, we can give her some antibiotics to prevent any infection. But if it is a large hematoma, obviously it would require drainage. So we have to take the patient to the OT, arrange for blood and products depending upon how much blood we expect she has already lost. And then we have to give the incision at the area of maximum bulge and then try to evacuate all the clots. Then suture it and close all the dead space. Ensure there are no bleeders in there. And if required, some people also put in a small drain, a neck suction drain, so that if there is any bleeding, that can, again, if there is bleeding, that can be, that gets a way out. A vaginal packing can be done for about 12 to 24 hours, and antibiotic cover should be given to the patient. Tranexamic acid again can be given to prevent this as an
any
antifungal.
hematoma, the size is increasing, and we have to explore the region, and we have to do it under anesthesia better for better visualization and analgesic also. So that is this thing. Small clot, we can leave it. So any points, the legal aspects of these kinds of life-threatening scenarios? What are we have managed the patient, but we have forgotten about the legal aspects. So what are the things we have to keep in mind simultaneously regarding the legal aspects?
First of all, proper documentation and explaining everything to the patient. Whenever the initial signs of PPH start appearing, we have to keep the attendants informed that the blood loss is going far from normal. We need blood transfusion, we need blood products, and we may have to shift her to a higher facility or a patient. A facility where blood bank and ICU are available. So keeping everything informed, taking consent for this, and making arrangements for blood products and the required things, and to keep a senior informed. And in case any complication or a death if occurs, then we have to keep our colleagues informed so that if any complications does arise, then they are available to help us.
Yes, exactly. So report proper documentation is very, very important in these kind of patients, because sometimes in spite of all our management, we lose the patient, then this documentation plays a very important role in the medical legal aspects also. And also, always a teamwork is what gives us a good result. We should call for help. That is the first thing in PPH. And also team so, are there any other questions or anything to be discussed? Ma'am, Sampath ma'am.
Yes, PAS, placenta accreta syndrome. Ramani madam will tell few points about PAS. Ramani madam has left.
Placenta accreta syndrome. Most commonly, it is seen along with the placenta previa, and over the previous scar, be it LSCS, or it could be hysterectomy or myomectomy, whatever be that. So this can easily be picked up during the antenatal scan. Okay.
Yes.
If you are going to find in the antenatal scan a low-lying placenta, then the next thing is you might find out whether it is an accreta syndrome or whether it is just a placenta previa. So that can, if you are not able to pick up with the ultrasound, maybe we can go in for a MRI, which can clearly make it out. So this, how we are going to manage this placenta accreta syndrome is be ready with all the blood and the blood products. Do it in a center where you have all the facilities, and then again get the consent for multiple massive transfusion protocol. Then for again for the obstetric hysterectomy part of it, and again for all the legal things, we need to debrief everything what we are going to do. So then the first thing is there are now two ways of managing placenta accreta syndrome. Like we need to go, we can plan a delivery of the baby with the in situ placenta. We can go for a cesarean hysterectomy. Otherwise, for patients who are wanting to have the uterus retained, we have many other techniques like the 3P technique, where you can excise the entire thing, accreta placenta entirely, that can be resected. But before that, it should be at least a senior person should do very well. You push the bladder down, you identify, then you can put the clamps, uterine clamps, infundibulous pelvic clamp, and everything should be put. Then only you can do it, so that quickly you can remove the placenta with the tissues, and then you can suturing can be done. And sometimes this placenta accreta syndrome can also be associated with infiltration. So in such conditions, you get the concern that you sometimes the bladder may be inadvertently open, and now the next thing is you have to close the bladder, so along with the continuous drainage. So all these things have to be explained. Otherwise, if the patient doesn't want conservation, then you can go ahead with the hysterectomy, doing a classical cesarean section, remove and then clamp everything quickly, and then go for a quick hysterectomy. Or if facilities are available for uterine artery embolization, I think that can also be another choice. And sometimes if you feel it is difficult to manage in the center where you have operated, deliver the baby, close the uterus, and transfer the patient to a higher center where it can be managed properly. Sampath, வேற என்ன add பண்ணோம்? I think I have.
Yes, I told. So if accreta percreta cases, as madam told, you have to do the MRI and get consent for obstetric hysterectomy. That's all. Saving the uterus is not important. Saving the mother is very important. So PPH, I think everything has been discussed. Tone, tissue, trauma, and finally that thrombosis. Wonderful. Anyway, thanks to the panelists. I don't know why 3 panelists didn't attend. Anyway, it was nice, Sugasmi. Thank you so much, Ramani madam. Thank you.
Thank you, Sampath. Thank you, Sugasmi, and thank you all the panelists.
Thank you, ma'am. Thank you, ma'am.
Thank you, ma'am.
Thank you, my panelists.
Very wonderful. Dr. Lakshmi, Dr. Anjana.
Dr. Sampath, thank you so much, and all the best.
All the best.
Excited to you.
So on behalf of me and entire Tamil Nadu, the request to Haryana state is, please do support Dr. Sampath Kumari, because we have not had any president from the south from Tamil Nadu for a long time. So kindly request all of you to support, not only support, kindly vote for Dr. Sampath.
Yes, sure.
Actually, give the members to vote.
Vote, yeah.
Thank
Very good. All
thank
the
you all.
members of your society vote. Thank you.
Thank you,
Radhika.
madam.
Thank
Thank
you,
you,
ma'am,
all
for
of
the
you.
opportunity.
Thank you, Radhika. Thank you
ma'am,
all.
for the opportunity.
Good night.
Bye. Good night, ma'am.
Good night. Saroj, madam, good night. Archana, Rashmi, all good night.